When we got to the point of having finished discussing the motor innervation in the upper limb, we said, well, what about cutaneous sensory innervation? And we talked about the sensory innervation to the hand. Well, in the lower limb, certainly we don't use the foot in the same way that we use the hand, so we don't have the same significance of cutaneous sensory innervation. But there is a fairly important region of distribution that's worth taking note of, and that is on the dorsum of the foot, on the dorsum of the foot. And this slide illustrates that the sensory innervation to the dorsum of the foot is provided by two nerves, the superficial fibular nerve and the deep fibular nerve. So the two branches of the common fibular nerve between them provide the sensory distribution to the dorsum of the foot. The reason that's important to know is that injury to the common fibular nerve is the most common peripheral nerve injury in the lower limb. And so an injury to the common fibular nerve can compromise sensation on the dorsum of the foot. The place where that nerve frequently gets injured is as the common fibular nerve, just after it crosses the knee, it lies in close contact with the head of the fibula. And because there is no muscle separating the nerve from the head of the fibula, the common fibular nerve can be pressed up against the head or neck of the fibula in that location, just distal to the knee. One particularly important way in which that might happen is in a patient to whom a long leg cast has been applied. If that cast crosses the knee, one has to be concerned that the common fibular nerve does not get compressed against the fibular head by that cast. And so by keeping the toes exposed in that cast on that patient, that allows you to test the sensation for the superficial fibular nerve and the deep fibular nerve, and thereby you're testing the entire cutaneous distribution of the common fibular nerve, so that if, let us say, edema is starting to develop in that lower limb and the common fibular nerve, which wasn't being compressed when the cast was initially applied, is now being compressed, you would know about that as the patient began to lose sensation in this area of distribution. So that's why that's worth knowing.